We're going to get into clinical stuff, and that's the good stuff. So the reason these lasers work is because of the wavelength. All tissue means it's going to cut all of these structures in the mouth. Hard tissue, meaning dent and enamel decay, composite removal, bone, soft tissue. It does all this because of absorption. So a target tissue needs to absorb that wavelength to be vaporized. So I'll just call it the laser. Targets hydroxyapatite, water, and collagen, and it vaporizes these tissues. It doesn't chip away, and it pulses, a couple thousand times a second, or at least several hundred times, depending on how hard you're hitting the foot pedal. Whereas the erbium lasers are pulsing, more like somewhere around 10 to 30, sometimes 50 pulses per second. So the speed of cut is much faster, and the precision, because of the vaporization of tissue, is just, unsurpassed. 2015 was my first year using the all tissue CO2 laser, and I had it for most of the year, not quite the entire year. And my first year, it was 36,000. 2016, it was 81,000. 2017, 107,000. 2018, 125,000. Everybody, there's plenty of people who can just do things faster and do more and work harder. It's not about doing all that. You're actually not working as hard. You're not killing yourself. This laser makes life easier, and you're delivering a better experience to your patients, and you're getting better outcomes. Previous dentist had just built the tooth structure up as well as he could to close those diastemas and let the tissue dictate how that would be. But that's what it looks like close up. That's what I want it to look like. All right, so I'm visualizing my end result. So what I did was laser the soft tissue away. So then I used the laser to remove the composite. We did some beveling and etching, obviously, and restored the tooth. Most of these can be done with topical. There are cases with these that I do have to give injections. Again, it depends on the child and the thickness of the tissue, and also we do these on adults as well. When I'm doing them on adult frenectomies, I'm much more likely to need to give an injection. I kind of liken it to tonsil removal on a kid versus an adult. It just becomes a more invasive procedure on an adult. There's definitely a genetic component for some patients, because I see her mother, and I see her grandmother, and I see her aunt, and they all have the same thin biotype and recession, and all have excellent hygiene and are very responsible, and they still have those problems. So first, I remove soft tissue. When I'm doing a flapless crown lengthening, we remove the soft tissue first and then hard tissue. So tooth number 8 and 9 were just soft tissue. Tooth number 7, we needed a little more, so I removed some bone also. And we're not going to get into the details of how I remove bone. So if you compare the pre-op to the 5-year post-op, it's a remarkable difference in her smile in this case. So we do some sounding of the bone so we know where we are and what we have to do, and we want to know where we are relative to the CEJ, etc. So this is immediate post-op. We've removed soft tissue and bone. So there's a pre-op and 3 weeks post-op. So he still has a little bit of a gummy smile, but it's much improved, and those teeth don't look so short. So I'm going to show you some stuff with implants. This is pre-op. This is immediate post-op. We uncover it and do the final impression or scan at the uncovery visit. This is a stark contrast. We have immediate post-op with the laser compared to 3 weeks post-op traditionally by a skilled, experienced oral surgeon.